I'm joined today by a pediatric dentist with a PhD. He's dedicated his research and dental practice to reduce surgical interventions and treat oral disease using combinations of prevention and minimally invasive techniques. Welcome, Dr. Jeremy Horst Keeper. Thank you
so much
for being here.
It's an honor.
Our focus today is on a product that has over 20 years of success outside the United States, and yet it was just approved by the FDA in 2024, and they use the following language: a gel cleanser intended to clean the interior of a prepared cavity of a tooth prior to self-etching bonding procedures. And the product's called Papacarie Duo. Tell us a little bit first, just how does it work?
Yeah, well, so Papacarie, the way that it works is it digests proteins. So it soaks into a carious lesion, and it's an enzyme that breaks down all proteins. So that could be dentin protein, bacterial protein, and makes it so that it'll just rinse away.
And yet it won't affect healthy dentin.
Exactly. So healthy dentin is mineralized, right? If you happen to know the proteins of dentin, DSPP, DPP, whatever, collagen, all these things, their trait is that they have mineral all around them. They have hydroxyapatite all around them. And so if they're surrounded by hydroxyapatite, then this enzyme cannot get them. So that's where the concept came for Papacarie, like you said, 20 years ago in Brazil, was that there had been this enzyme that was known for a long time, papaya sap, that was used as a medicine for thousands of years to treat digestive or indigestion and issues in the upper GI tract. And it had been used in modern science for 40, 50 years, maybe longer. When you're isolating DNA or RNA, you need to break down the protein so the protein doesn't digest the RNA. And you just put in papain. So whenever every single biology laboratory I've ever been in has papain, it's papaya extract. So the same concept applies here, is saying, we want to get rid of stuff that still has protein that doesn't wash away. What is that? That's demineralized dentin that probably can't remineralize. We don't want to get rid of the mineralized dentin. We do want to get rid of bacteria, obviously, and so it does that extremely well. It's been used, as I said, for thousands of years by pre-European societies in South America, Central America, Caribbean, just papaya sap, and then it's been used in biology laboratories where it's very easy to isolate that one enzyme. So the safety of it for humans is remarkable. The longevity of use, the understanding of how it works has really been there. And so we're just applying it to dentistry. So there's always a question: are you going to drill too far? Are you not going to drill enough? You leave the bacteria there. How are you going to make sure to have a solid enough foundation for your restoration so that you can put your composite, glass ionomer, whatever it is, on the tooth and trust that the tooth is going to support it, especially on the pulpal aspect of that carious lesion. So you literally just put this product on. It's a gel, so it doesn't run, just stays where you put it. I do 60 seconds. Technically, if you look at the studies from Brazil that have clinical trials that have gone for a long time, you can just leave it. I like to agitate it with a little micro brush. You can use a spoon excavator if you want. I use just a little micro brush and just move it around for that 60 seconds to help it get wherever it needs to go. And then you rinse it away. And then you're ready to go ahead and put your restorative material on. Every now and then, so I'm a pediatric. I was trained in pediatric dentistry, and now I'm doing all ages. And so I've been humbled by the subgingival root caries in older adults. From the proximal that go underneath an old crown, root canal treatment. Oh my God, it's really deep. A couple of those, I've had to apply it twice.
Okay,
and that's it. Everything else is one time.
Well, that's fantastic. So you're not having to spoon excavate the decay after. This is dissolving it, and the decay is being swept away when you rinse away.
Exactly.
And with your practice of all ages now, what are some of the places where you're using it? Is it a situational specific where you use it, or is it everybody that has decay, I'm using this product? How do you apply that?
That's a great question. So for me, there's sort of two tracks for let's say there's three tracks for restoration. One is where you really don't need to do any caries excavation. Maybe you would just call it a sealant, a therapeutic what PRR type of thing, where I'm really not excavating like an occlusal surface. Okay, let's throw that away. Second one for me, I've been using silver fluoride during the diagnostic visit. When I see a cavity, I put silver fluoride on, and then at the restorative visit, I don't need to do very much caries excavation at all, because the silver fluoride has hardened the caries lesion into this really hard substructure. Now that caries lesion turned black, which a lot of times is fine, and a lot of times is not fine. So that's one route for me, is to use silver fluoride to harden a caries lesion, and then I'll just go and put the restorative on it a week later when the lesion's really hard. Now, if I'm, for whatever reason, if I'm not putting silver fluoride on a tooth, then when I come to the restorative interaction, then I'm using this Papacarie. And so that could be a same-day treatment where I'm seeing the lesion for the first time. We have the time, the patient has the bandwidth, financially and time-wise, for me to go ahead and restore. So I can trust that I'm using Papacarie. There's not going to be any discoloration of my restoration. If I put silver fluoride on, first of all, it takes days for the lesion to harden. So that's not going to be sufficient. And also, obviously, it'll, unless you're really careful, it will color your restoration. So Papacarie has been a great solution for these last 5 months while we've been open here, to have a same-day restoration without needles or drills.
Wow.
So that's kind of my buckets where I've been using it.
So if I were to use Papacarie first and remove decay, if I applied SDF after, it's not going to stain because the decay is gone, right? Or would it still stain a little bit of that hardened dentin, do you think?
That's a really good question. My primary concern would be whether it would stain your restoration.
Okay.
So if it's placed the same day, what a lot of people have been doing, I think Doug Young first accidentally did this. He was a faculty at UOP and came up with the term Canberra. If you've heard of Canberra, Doug Young instantiated that term. He was using SDF. He was one of the first people, and he's sort of the U.S. king of glass ionomer, I call him. He would say, no, it's other people, but he's my mentor on it anyway. So he's been putting SDF, like you said, excavation, SDF, and then glass ionomer. And what he was doing, what he didn't realize, is he was using really bright overhead lights or loop lights and precipitating out the silver, then cleaning the margins to just past the DEJ, and then placing his restoration. Now, his restorations didn't stain because he had precipitated out the silver. Oh. So you can do that with a curing light, you can do that with an overhead light, but you basically want to, if you're doing SDF and a restoration the same day and you don't want the restoration to turn black, I would strongly recommend to hit it with, let it absorb in for a full 2 minutes or so to really get into the tooth. And then remove the excess with some cotton or whatever you want to use, and then hit it with a light, and you'll see wherever it is. And then you can decide where you want to clean it up or whatever. But that's only because you're covering it, right? So like you said, if you just used Papacarie and let it soak in for a minute, do its job, and then rinse it out, and then put SDF on and left it like that, it would not stain.
Yeah.
Problem is you're sealing in the silver fluoride if you put a restoration on it that day, and that silver fluoride needs somewhere to go. It's going to go into the tooth. It's going to go into your restoration. So that's where you just want to be a little careful of this thing.
So walk me through the procedure when you're applying the Papacarie Duo. So I've come in, I've got a carious lesion, and I want a restoration today, a definitive restoration.
Yep. Yeah. So, isolation requirements are really minimal. Again, people have been swallowing this stuff for thousands of years. It does digest protein, so you may see a little bit of reaction, on the tongue or something like that, but it's some safe stuff. So for me, I use glass ionomer, so I don't use a rubber dam most of the time. Okay. I don't use a rubber dam at all in my practice because there are no needles, no drills. But glass ionomer needs moisture. So we usually just use, even if I wasn't in a no needle, no drill situation, I would not be using a rubber dam most of the time. So this is how I do it. Cotton isolation, literally. I just have, the saliva ejector, removing any saliva that pools. I would do an initial cleaning of the tooth, whether that's with something like aerabrasion or a toothbrush or whatever you want, to just get rid of the Cheetos and Fritos and meat or whatever's in the tooth. And then literally the first next step is to have a little plastic dapping dish, a micro brush, just like we would use to place a bonding agent or silver diamine fluoride, and I apply it in, and you can see that it starts to interact with the material. So I make sure that the carious lesion is fully wet all the way out to the periphery of the tooth. Again, enamel has basically no protein in it, but there can be bacteria hiding in the irregularities of the enamel. So I do apply it all the way to past the DEJ to the enamel, and certainly down to the base of the lesion. I then use that same microbrush once the lesion is totally wet to just agitate it around. If there are clumps of carious dentin or clumps of bacteria, then this will just help to make sure that the papain, the papaya enzyme, gets throughout those materials. I have a timer going for 60 seconds, and I just agitate it, just gently move it around for a minute. After the minute, I put that down, suction it, and then rinse. At that point, you can look at your prep, and it looks shiny and clean. So if there's anything you want to do at that point, either take a burr to improve your cable surface margin or retentive features or something like that, sure. I use hand instruments, and what I find is that in carious lesions that are of this, where I'm using this, they already have kind of a retentive shape to them. They have some kind of bowl feature to them usually, and if not, then you put in a little retentive feature. And then you go about placing your restoration. I mean, that's literally it. So it's very efficient.
Do you need to use a handpiece, though, sometimes just to access the lesion a little better, particularly if it's a class 2?
Now, I'm a weirdo, right? So I'm actually referring out my cavitated class 2 caries because I'm doing this off-the-wall thing of no needles and no drills. So if I have a carious lesion that's into the middle third of the dentin on a permanent tooth, that's a class 2, and I can't do that without a needle or a drill. So yes, if I was doing that, then I would need to use the handpiece to access. So you do your standard access form, your standard GB black or modern outline. And then apply it.
And the restorative material that you're using or that you like to use, glass ionomer.
Yeah, we're using the glass hybrids. So the modern incarnation of glass ionomers is the GC Equia Forte or the Keytac Universal. Gotcha. You're probably familiar with that, where they took the polyacrylic acid chain and just made it really long. And you're probably familiar, Gordon Christensen and Rella Christensen's track. They did a study of like 20 different materials on huge class 2s, what most of us dentists would call needing a crown. And the only materials that held up consistently for cable surface margin integrity and recurrent caries were those 2 materials I mentioned. So we're using those, and I've been using that for 8 years now, 9 years, just right when it came out, and it's been fantastic. We're seeing really, really, really good responses.
So in this instance, this is a definitive treatment. So when it comes to, everybody wants to know, how do I bill? Because they think it's something new or different. Are you treating this the same as you would any other restoration? In other words, you're just building for how many surfaces it is?
You bet. Yeah. I mean, if you go read the CDT part on composite resin, it says it includes a glass ionomer, it's a restoration. So how this helps me is I didn't talk about local anesthetic, right? So I'm able to excavate carious lesions without sending the patient away, right? My silver fluoride protocol, we call the 2-visit SMART, I have to send the patient away and then back. This enables me to do it at the same time I meet the person for the first time without needles or drills. And so it's very efficient that way. So to me, the use of this material saves me time and money. It saves it, and it opens up treatment to phobic patients who are afraid of needles or drills, or people that just don't like to be numb. They're going back to work and they don't want to have, feel like half their face is slouching. So I think that's the value proposition, is that it, saves me a burr, it saves me time, it opens up more patients, and all of that. So that's where I think you just have to include it in your restoration cost.
Yeah. Wow, that's fantastic. Are there any other things that you want to add? Any other tips or tricks or suggestions when people are using this? Things to be aware of, to be careful of?
In terms of caution, I'd just say again, this is literally papaya sap that has been consumed by people, used as a meat tenderizer for like tough meat for thousands of years. And it's been used in dentistry for 20 years in Brazil.
Yeah.
And very common, very standard there. So, if this didn't have a place in modern dentistry, it would have disappeared.
Right.
But the fact that it's been used in Brazil for this whole time, and some of the other countries in South America, like Argentina, I think demonstrates the value to the dental team and certainly to the patient. I think keep it simple is always a maxim. You had prompted me before the recording about Caries indicator, and so I don't use Caries indicator with this because I have seen so many studies on this over the 20-something years that it's been in Brazil. But yes, you can use Caries indicator if you want to, if that's your standard protocol. If you want to convince yourself. But I would say that, all the different Caries indicators, the Danville or whatever, you may still get a little bit of staining on the pulpal aspect. Yeah. Maybe, I don't know, depending on what indicator you use, but I would say leave that alone.
Right. Trust the Papacarie Duo.
Because what do you really need for your restoration, right? You need retention, you need access, but really what you need is a seal. You want to seal that lesion. You want to maintain the seal of that lesion. So the pulpal aspect, if there's a little bit of something going on, as long as you can seal it properly, that restoration is going to be great. Now you need to support the seal with the base of your dentin.
Yep.
But you don't need the very bottom of the pulp. So I don't know. I would just say don't go too far with a Caries indicator. If you want to play with it the first couple times, hey, see what it does and all of that. Absolutely.
Yeah.
But I would say I imagine that you'll be convinced pretty quickly to put down the Caries indicator and just use the Papacarie as your removal agent.
Fantastic. Dr. Jeremy Horstkeeper, thank you so much for your time. I really appreciate the information. This is very exciting.
It's an honor and a privilege, and I'm very grateful that you're spending this time and energy on this next advancement in non-invasive care.
Thank you.